Good morning, everyone. So today we are talking about pathologies of the knee. I'm also going to do ankle as well, and hopefully upload all of that today. So you guys have all week to do knee homework, ankle homework, and then get ready to turn in your final by Friday. Last week of class. So if you have any questions or feel like you're missing something, please email me and let me know. And we can talk through strategy to get all of that done. So let's get started with the knee. Again, we're going off of slides, and that is uploaded for you, so we'll go ahead and get started. Slide 2, we're looking at anatomy of the knee. So the knee is a complex joint that is frequently injured during participation in physical activity. I would say maybe the most frequently injured. While walking and running, the knee moves through a considerable range of motion while bearing loads which are equivalent to 3- or 4-fold the person's body weight. So because the knee is positioned between the two longest bones in the body, the femur and the tibia, the potential exists for creating large torques at that joint, which cause big injuries. So those factors, coupled with minimal bony stability, it makes the knee very susceptible to injury. The knee is predominant site of injury among runners and is one of the most frequently injured joints in sports participation. So we'll start with review of anatomy of the knee, and then we'll discuss some of the kinematics of the knee, and then we'll go in and we'll look at common sports injuries that we see, and then the management of what that looks like. We'll also talk about range of motion and assessment of those injuries, so that you guys have an idea of how to go into your homework. So like I said, slide 2, we are looking at anatomy of the knee. The knee is a large synovial joint that includes 3 articulations within the joint capsule. The weight-bearing joints are the 2 condylar articulations of the tibiofemoral joint. The third articulation is the patellofemoral joint. The soft tissue connections of the proximal tibiofibular joint also exert minor influence on knee motion. So we have bony structure of the knee. Proximal bone of the knee is the femur, the longest and strongest bone in the body. The prominent posterior ridge of the femur serves as an attachment for many of the muscles that move the hip and knee. The distal portion of the femur broadens to form the medial and lateral epicondyles. The area between the epicondyles on the anterior surface of the femur is the femoral trochlea, through which the patella glides as the knee moves in flexion and extension. So that joint is really important. The lateral epicondyle is wider than the medial epicondyle. Arising from the most superior crest of the medial epicondyle is the palpable adductor tubercle. So that's another important attachment site for muscles and structures. So then corresponding to the femoral condyles are the medial and lateral tibial plateaus. So that is where they come together and form the joint. To accommodate for the longer medial femoral condyle, the medial tibial plateau is 50% larger than the lateral tibial plateau. So then the anterior aspect of the tibia includes the prominent tibial tubercle, another big attachment site that we're looking at for muscles and structures. The patella is a sesamoid bone located in the quadriceps or patellar tendon. It improves the biomechanical function of the extensor mechanism, and it protects the anterior portion of the knee. The fibula is not a direct part of the knee joint. The head of the fibula, however, does serve as a site for several soft tissue attachments that support and stabilize the knee. So we talked a little bit, I mentioned the patellofemoral joint, and that's where the patella sits in those femoral grooves. And then it glides through, it's embedded in the patellar tendon, so it glides with that muscle and that movement. All right, slide 3, we're talking about the tibiofemoral joint. The distal femur and the proximal tibia articulate to form two side-by-side condyloid joints that collectively are known as the tibiofemoral joint. These joints function together primarily as a modified hinge joint. Because of the restricting ligaments, some lateral and rotational motions are allowed at that joint. The medial and lateral condyles of the femur differ somewhat in size, shape, and orientation. As a result, the tibia rotates laterally on the femur during the last few degrees of extension to produce locking of the knee. So here we're looking at the phenomenon known as the screw-home mechanism, and that is rotation of the tibia on the femur at the end of extension, producing that locking of the knee in a closed packed position. So that's important because injury will sometimes prevent that mechanism from happening, and so if that's not happening, that can be indicative to what structures might be injured. Ligaments and muscles attribute to the screw-home mechanism, so we'll talk about those when we're looking at injuries. On slide 4, we talk about the meniscus in the knee. So you have two. The menisci are also known as semilunar cartilages because of their half-moon shapes. They're discs of fibrocartilage firmly attached to the superior plateaus of the tibia by the coronary ligaments and the joint capsule. They provide several functional advantages, including and mainly absorption and dissipation of force and significantly improved congruency of the joint surfaces. This helps to evenly distribute stress and across the joint. 74% of the total weight of the menisci is water. Much of that fluid is squeezed out into the joint space when the knee undergoes compression during even walking and weight bearing. You have a medial meniscus and a lateral meniscus, so two half moons, one on each side, and you can see that in the picture that's on this slide. The inner edges of the meniscus on both sides are unattached. And so this means that there's only blood flow on the outer edges where it is attached. The anterior and posterior horns are attached to the intercondylar tubercles, and those are the only places where they are attached. This can also mean that injury is, there can be different types of injuries to the meniscus, so we'll talk about those when we get down into injury. And then the surgical intervention is different for these because blood flow is poor and its healing process is a little bit different. On slide 5, we start talking about ligaments of the knee. Because the shallow articular surfaces of the tibiofemoral joint, they contribute minimally to knee stability, so the stabilizing role of the ligaments crossing the knee is really important here. Two major ligaments of the knee are the anterior and posterior cruciate ligaments. The name cruciate is derived from the fact that the two ligaments cross each other within the joint. So with anterior and posterior referencing their respective tibial attachments. So anterior cruciate ligament attaches to the anterior portion of the tibial plateau. Posterior cruciate ligament attaches to the posterior part of the tibial plateau. These ligaments are also termed intracapsular ligaments because they're located within the articular capsule, and extrasynovial ligaments because they lie outside the synovial capsule. So the anterior cruciate ligament is a key knee stabilizer. It connects the femur to the tibia, and it resists anterior tibial translation and rotational loads. Posterior cruciate ligament is also a key knee stabilizer, and it connects the tibia to the femur as well, but on that posterior side. The PCL is twice as thick as the ACL, and it prevents the tibia from excessive posterior displacement in relation to the femur. And then we have the medial and lateral collateral ligaments. They're also referred to as the tibial and fibular collateral ligaments, although I don't use that term in the clinic at all. They're formed by two layers. The deep fibers of the MCL merge with the joint capsule and the medial meniscus to connect the medial epicondyle of the femur to the medial tibia. The MCL is taut in, or a little bit relaxed in complete extension. In mid-range, its posterior fibers are the most taut, and then in complete flexion, the anterior fibers are the most taut. The lateral collateral ligament connects the lateral epicondyle of the femur to the head of the fibula, contributing to lateral stability of the knee. The ligament is separated from the lateral meniscus by a small fat pad. The LCL is the primary restraint against varus forces when the knee is between full extension and 30 degrees of flexion, and it provides secondary restraint against external rotation of the tibia on the femur. So there's pictures of the ligament on the slide. It doesn't necessarily point out the MCL and the LCL, but you can clearly see them on the inside and outside, or the medial and lateral portions of the knee as well. All right, on slide 6, I gave you a visual for muscles of the knee and the thigh. These should be familiar to you. Anterior view and a posterior view, so review those. Here we do have muscles that cross the knee, so that's very important to remember as well. Attachment sites are not necessarily, or they are important here, and so just reviewing those for you guys. On slide 7, we're looking at kinematics and major muscle actions of the knee. So the knee functions primarily as a hinge joint, and the different shapes of the femoral condyles serve to complicate joint function. So main actions here are flexion and extension. So the primary motions permitted at the tibiofemoral joint are flexion and extension. Knee flexion is performed primarily by the hamstrings, and it is assisted by the popliteus, gastrocnemius, gracilis, and sartorius. In addition, the flexor musculature has a secondary responsibility of rotating the tibia. The flexors attaching on the tibia's medial side internally rotate the tibia, whereas those attaching on the lateral side externally rotate the tibia. Again, we talked about the screw home mechanism, so we're not going to go too much into that or too far. There's a lot of angles here at the knee when we're talking about the patella and how it glides in the patellofemoral joint within flexion and extension. But for the sake of this course, we're just going to talk about range of motion in flexion and extension here. We're not going to talk about the Q angle or how the patella sits in the groove or anything like that. So rotation and passive adduction and abduction does occur at the knee as well. The rotation capability of the tibia with respect to the femur is maximal at approximately 90 degrees of knee flexion. A few degrees of passive abduction and adduction are permitted when the joint is positioned around 30 degrees of flexion. Obviously, your knee contributes to gait as well, so knee motion during gait is very important to look at too. So during mid-stance of normal gait, the knee is flexed to approximately 20 degrees, internally rotated approximately 5 degrees, and then also slightly abducted. Knee motion during the swing phase includes approximately 70 degrees of flexion, 15 degrees of external rotation, and 5 degrees of adduction. We're not going to do gait analysis in this class. It could be its own class by itself. So just knowing that different angles are happening at different portions of the different phases of gait. And then we have the patellofemoral joint motion. So during movements of knee flexion and extension, the patella glides into the trochlear groove, primarily in a vertical direction. So the patella can sit differently within that groove, and then how it's positioned within the patellar tendon also plays a role. How strong the quad is, how deep the groove is within the bones. A lot of anatomical things can occur here. So we'll talk about the patella injury on a different slide, but just knowing here that that motion generally happens vertically. If motion is happening horizontally or rotationally, then we're having some angle problems and then some muscle instability and imbalance that's happening. All right, so slide 8, we're looking at our first injury to the knee. So we will talk about contusions, as we do in most chapters. Contusions result from compressive force that we've talked about before. They're common at the knee because it's generally one of the things that catches you when you fall. General signs and symptoms include localized tenderness, pain, swelling, and ecchymosis. The knee does swell quite a bit depending on the injury, so sometimes injuries can be obscured if swelling is extensive. So the first one we look at is a fat pad contusion. The infrapatellar fat pad may become entrapped between the femur and the tibia, or it can become inflamed during an arthroscopic procedure, which can lead to a tender, puffy fat pad contusion. Signs and symptoms here are locking, catching, the knee giving way. There can be palpable pain on either side of the patellar tendon, and then extreme pain on forced extension. So here we would manage with ice and compression and elevation, NSAIDs. Participation in this case is not limited. You can use a brace or a sleeve to protect from further injury, but they can still participate if they have a contusion like this going on. The second contusion we're going to talk about is a peroneal nerve contusion. The common peroneal nerve leaves the popliteal space and winds around the fibular neck to supply motor and sensory function to the anterior and lateral compartments of the lower leg. So a kick or a blow to the posterolateral aspect of the knee can contuse this nerve, which can lead to temporary or permanent paralysis. The nerve may also be injured by prolonged compression from a knee brace or an ACE wrap. If you're squatting for a long time in cases like baseball catcher or softball catcher, those kinds of things can cause injury to the peroneal nerve. Signs and symptoms here would be a shocking feeling, tingling and numbness, they might linger. Swelling may occur within the nerve sheath, and then muscle weakness may be present. Management is the same as acute care for contusions. If the condition does not rapidly improve, however, it's necessary to monitor any sensory changes or motor weakness as indicated, and then the first signs of change, you would refer the individual to a physician if that does not get better quickly. Slide 9, we're looking at bursitis again. So we've talked about what causes bursitis, and then here we have another bursa that we will look at. It's the prepatellar bursa. It's injured more often by direct blows and shearing forces. Inflammation is caused by overuse and subsequent friction. As you can see in the picture, signs and symptoms would be extreme swelling. They can have pain. Management would be ice, compression, NSAIDs, and rest. You can also use protective padding to prevent direct blows from happening to that area again. All right, slide 10, we're looking at the ACL tear. So the ACL, it can be injured in several ways. Changing directions rapidly, stopping or decelerating suddenly, slowing down while running, so the deceleration, landing from a jump incorrectly, direct contact or collision can also tear the ACL. Several studies have shown that female athletes have a higher incidence of ACL injury than male athletes, and in certain sports. It has been it has been proposed that this is due to differences in physical conditioning, muscular strength, and neuromuscular control. Other suggested causes include differences in the pelvis and lower extremity alignment, so those angles that I was talking about. They could have increased looseness in their ligaments, and then the effects of estrogen on ligament properties is also very different. It's not exactly known why, but incidence of injury is a lot higher in females than in males. And then ACL tear can occur by itself, but a lot of times it occurs with other injuries as well, either a meniscus injury, an MCL or an LCL injury. Contusions, bone contusions are very common here. And all of those will be seen on an MRI, which is required to firmly diagnose an ACL tear. So signs and symptoms would be pain with swelling, lots of swelling here, loss of full range of motion, tenderness along the joint line, discomfort while walking, and then laxity or instability within the knee. Because that joint is, or because that ligament is torn, that translation of the tibia on the femur is much looser than what it should be, and that will be felt. I'll explain that when we talk about the ligament stress tests for assessment of an ACL tear. So management here is referral to a physician. Athletic trainers can do stress tests, and we can what's the word? We can feel when they have an ACL tear. However, we cannot firmly diagnose an ACL tear, especially one that only occurs by itself. So you need to have an MRI to confirm an ACL tear, confirm any other injury that is happening in the knee. And then it's always surgical. Surgery is there is different procedures that can happen. I'm sorry, I got a little jumbled there. So what you have to do is you have to regraft the ACL. It doesn't have blood flow, so you can't just sew it back together. You need to create a new ligament and put it there. So there are different grafts that you can use. An autograft is when you take tissue from your own body and build a ligament out of that. That is the most common way to repair an ACL. They will either use the patellar tendon, they'll take a piece from the patellar tendon, or they will take a piece from a hamstring tendon of the same leg that is injured. So then you can rehab both of those at the same time. Most common, I believe, is patellar tendon. I have seen a couple hamstring tendons as well, but most common, I think, is patellar tendon. The second one is an autograft, and so that is when you take a cadaver graft and you use that to build a new ligament. So it's not coming from your own body, it is coming from a donor body. You can also have a synthetic graft. This is like last resort. You've torn your ACL multiple times, and those grafts keep failing. So then they will use synthetic materials to build an ACL out of that instead. Least common. It does not happen super often, but in some cases it is necessary. On slide 11, we're looking at the PCL tear. So this typically requires a powerful force, a direct blow to the front of the knee, pulling or stretching the ligament, and then also a simple misstep can tear this as well. Because it is 3 times as thick as the ACL, it is not injured as often as the ACL. Signs and symptoms here would be pain with swelling, difficulty walking, but not necessarily surgical. People can live and play sports with a torn PCL. It's not as important as the ACL, so you can do therapeutic rehabilitation and strengthening to compensate for the PCL being torn. Again, it doesn't repair itself. It doesn't just grow back together, but you don't necessarily have to repair it in order to live a normal life and play sports. Slide 12, we have MCL and LCL tears. So we have straight medial instability. So valgus instability is caused by lateral forces, which cause tension on the medial aspect of the knee. These are also graded like other strains that we have seen, or other sprains, I'm sorry. Grade 1 would be mild pain around the medial joint line, little to no joint effusion. Full range of motion is possible, but it might be uncomfortable, and there will be total joint stability here. Grade 2, they might be unable to fully extend their knee, and you'll start to feel a little bit of laxity in that MCL joint when you're testing. Grade 3 would be a positive valgus test with a soft or an absent end feel. So you'll feel when you do the stress test that there's no end feel, or it's a very soft end feel, and you'll feel kind of the joint of the knee opening up a little bit. Straight lateral instability is a varus instability, and that's when medial forces cause tension on the lateral aspect of the knee. So signs and symptoms here, grade 1 would be mild pain around the lateral joint line, little to no joint effusion, full range of motion that might be uncomfortable, and then joint stability is present. Grade 2, the patient may be unable to fully extend their knee, and then grade 3 would be a positive varus stress test with a soft or absent end feel as well. Slide 13. We are looking at knee dislocations. Let me find my spot. Where did it go? That's okay. So knee dislocations, there's not a ton of range of motion in other directions than extension and flexion here. So dislocation of the knee can be catastrophic. I linked a video here for you guys. About a year and a half ago, there was an Auburn gymnast who dislocated both knees. There is a video. I linked it here so you guys can go watch it if you want to. It is very graphic, but you can see everything that's happening in a knee dislocation. So you can go and watch that if you want to. If you don't want to, that's totally fine. That's why I did not include a picture, because it can be pretty graphic and make you uncomfortable. Signs and symptoms here would be obvious deformity, immediate pain and swelling. They could have numbness and tingling. There's a lot of vasculature that's happening and nerves that go through there. And so with a knee dislocation, numbness and tingling is a big sign and symptom. They also might hear a loud pop. They can hear those structures that are being damaged when the knee is dislocated. Management here would be immediate care and then activating EMS. If you approach the athlete and the knee is still dislocated, obvious, activate EMS. If they felt that the knee dislocated and it went back in on its own, you can do your assessment, but immediate care as well. You want to get images, make sure that there's no vascular damage that could be catastrophic. If vascular injury is left untreated, it can result in amputation and loss of function in that leg. Also, this can be career-ending. Even if it is rehabbed correctly, even if surgery is done right away and rehabilitation is gone all the way through, they may never return to sport. This happened with an athlete that I had last year. She injured both knees, dislocated one, but injured both knees Tore both ACLs, both LCLs, and then she had patellar tendon grafts in both knees, but she was not able to return to gymnastics. She has rehabbed fully, has full strength, is extremely strong and able to run and do all kinds of activity, but gymnastics just was not something that she could return back to. All right, slide 15, we're looking at meniscus injuries. They're injured in manners similar to ligament injuries. On the slide you see a picture, and those are different ways that you can tear your meniscus. So with age, the meniscus becomes stiffer and less resilient. Sport demands also can make that progressive faster. Medial meniscus damage is more common than lateral meniscus damage. Signs and symptoms for a meniscus injury would be localized pain and then joint line tenderness. There might be delayed swelling here. It can show up 24 to 48 hours after injury. It won't blow up right away. And then there's going to be pain on rotation and then extreme flexion. The patient also might complain of catching of the knee, or it feels like they can't straighten it all the way, it gets kind of stuck. That is a really big indicator of a meniscus injury. Management here would be ice, rest, compression, and NSAIDs. You would do a physician referral just to confirm a meniscus injury, because knowing what type of meniscus injury it is very important for how you fix it. They can be surgical because they don't repair themselves. Again, the blood flow is poor here, so surgical intervention is fairly common. It's an arthroscopic procedure, so the scars are very, very small, but they do need to be fixed. Another surgical intervention here would be to take out the meniscus. Sometimes that is what's best for the athlete. The recovery is much quicker, and so sometimes taking it out makes much more sense. I've had athletes that had it removed and they returned within 6 weeks and they are fully functional. There is a risk of developing arthritis much quicker, but that is a risk that they make the decision to take. On slide 16, we're looking at patellofemoral stress syndrome. Let's see here. There we go. It's also called lateral patellar compression syndrome. It's pain in the patellofemoral joint without documented instability. So the condition often occurs when either the VMO is weak or the lateral retinaculum that holds the patella in the condyle is excessively tight. Pain results with a tense lateral retinaculum passes over the trochlear groove, or when increased patellofemoral stresses are transferred from the articular cartilage to pain fibers in the subchondral bone. So signs and symptoms, the individual may report a dull aching pain in the anterior knee that is made worse by squatting or sitting in a tight space with the knee flexed. Also, descending stairs or slopes would be pretty uncomfortable. Point tenderness can be located over the lateral facet of the patella, with intense pain and crepitus elicited when the patella is manually compressed into the patellofemoral groove. So that's one of the tests that we'll talk about. You press on top of the patella and then ask them to make a really strong quad. And that patella will push into the groove, and there will be crepitus that you'll be able to feel there. Synovial inflammation might also be present here. Treatment involves standard acute care and then the use of NSAIDs. Here you would test for gait analysis, flexibility, strength of the proximal and distal portions of the leg. It's important to determine the presence of decreased rotation or strength in the lateral rotators of the hip, as well as tightness in the hamstrings, the quadricep, and the Achilles tendon. You can also do tapings to the patella to try and get it to track a little bit differently. And then you would do a lot of strengthening within the lower extremity. You can also do soft tissue work on the quad if extreme tightness is one of the problems that's causing that injury. Slide 17, we are looking at a condition called chondromalacia patella. It's a true degeneration of the articular cartilage of the patella, which results when compressive forces exceed the normal range of motion, or exceed the normal physical range, or when alterations in patella movement produce abnormal shear forces on the backside of that patella. So there is a picture on the slide there that you can see the 4 stages, and the description explains what each stage you're looking at. Management here, a lot of times it's asymptomatic. Most people have some form of this happening on the backside of their patella, and they just don't know because it doesn't bother them. So asymptomatic does not require any treatment because the person won't be complaining of anything, so there's nothing to treat. They might not even know that it's happening. Most people respond well to the use of NSAIDs. You can also do quadricep strengthening and then hamstring flexibility as well. They could also wear a knee sleeve with a little cutout so that their patella can sit in the middle of that, and it helps it kind of stay in place. And then helps that motion that's happening there. But compression will also feel good and help them to be more comfortable. On slide 18, we have a patellar dislocation. This is an acute episode. It occurs when the patella has normal or abnormal alignment in the groove, but it's displaced by internal or external forces. Displacement can range from microinstability to subluxation or to gross dislocation, which is what we see in the picture on the slide. Factors that may lead to this alignment includes VMO weakness, hypertrophy, high and lateral patellar posture, an increased Q angle, and then also a bony deformity can all contribute to a dislocation here. So, like I said, it can completely dislocate or it can sublux. All signs and symptoms, if it has completely dislocated, it will be an obvious deformity like we see in the picture. Excuse me. The athlete will feel immediate pain, and there will be a big popping sound that they will hear as that patella is translating over those grooves. Management would be immediate care. If it stays dislocated, it would be an EMS call. You want them to get reduced as soon as possible. Again, that's something that athletic trainers are not, it's not in our scope of practice, so it's something that we do not do in the field. If it subluxes or goes back in on its own, you would still refer them to rule out any other injury. You would put them in a straight leg brace and then acute care. And then once they're starting to feel better, when they can bear weight, you can start doing quadricep strengthening and hamstring flexibility. This still takes about 6 weeks to rehab, as long as there's no other injury that has happened. Slide 19, we're looking at patellar tendinitis. Inflammation and tenderness occurs from repetitive or eccentric knee extension activities. There's a lot of contributing factors to this, especially if it comes on suddenly, or it starts to be an issue when it wasn't before. So you want to look at anything that changed, or what factor might be contributing to that. So types of shoes, playing surfaces, gait mechanics, years of play, warm-up tendencies, and stretching regimens will all contribute to patellar tendinitis, and sometimes it's hard to pinpoint what exactly is the cause. Signs and symptoms would be chronic anterior knee pain. There will be an insidious onset, so it will gradually get worse and worse. But again, if it's something that they're starting to feel in college that they've never had before, there might be one of those contributing factors there. They'll have pain going up and down stairs, and then pain during activity, and it will also linger afterwards. So the picture on this slide here explains management for patellar tendinitis. Rest for 2 to 3 weeks to allow those symptoms to subside. You can use modalities during those stages, including heat therapy. One of my favorites is to use phonophoresis with the ultrasound and putting a gel on the patellar tendon and then using ultrasound to get that medicine deep down into the tendon. Eccentric strengthening has proven to be one of the biggest, one of the most helpful forms of rehab for patellar tendinitis, and those can be found in research articles or rehab protocols. And then a patellofemoral knee sleeve can also help reduce mobility of the patellar tendon during activity. All right, on slide 20, we're starting to look at palpation when we are doing our assessment. So again, anterior palpation and posterior palpation are happening here. So now that we're at the knee, this is something that you should be able to do on yourself fairly easily with the knowledge you already have from anatomy and previous classes, and then this guide to give you an idea of how to palpate around the knee in a appropriate order. So you can go ahead and do that on yourself, or again, if you have someone at home that you've been practicing on, you can do that on them as well. Slide 21, we look at range of motion. Here we see active movement and then also resisted manual muscle testing. The first picture on the slide is showing how to measure knee flexion and extension with a goniometer, which I believe you have also worked on in other courses. So knee flexion, you can range from 0 to 135 degrees of flexion, and the knee extension is 0 to 15 degrees. Resisted manual muscle testing will also happen here. There's some pictures showing you how to do knee extension. You can also do ankle plantar flexion, ankle dorsiflexion, knee flexion, and then we'll talk about the myotomes in a later slide. In slide 22, we start looking at stress tests to diagnose some of these injuries that we've talked about. So we have 2 ACL tests, 2 PCL tests, and then an LCL and an MCL test. So the first picture, the top picture, is to do the anterior drawer tests. So this one you would actually do you can do for ACL and PCL. Same positioning and everything, but your force is going to be different depending on which one you're testing. So the knee is flexed, and the examiner applies an anterior and posterior displacement force on the proximal tibia. So you're kind of holding on the patellar. Your fingers should be on the hamstrings in the back, and then your thumbs should be on those tibial grooves in the front. So to test the ACL, you're pulling forward on the tibia and trying to translate it on the femur. If you feel a lot of movement there, indication for an ACL tear. If you feel it kind of move, but there's also an end feel where it stops moving, that is a strong ACL. Some people have some laxity in their ACL, which is okay, and you'll feel that in that test. Same positioning, thumbs in the front, and then you'll push back on the tibia and translating back on the femur, and that is to test the PCL. On the slide, let's see. The bottom pictures of the slide, we're looking at valgus and varus stress test. This you can test in straight leg or also at 30 degrees of flexion. And so depending on, again, you do the test the same way for interior or for lateral and medial. And so you're pushing in or you're pushing out depending on which ligament you're testing. This is similar to what we talked about in the elbow, but now we're doing it at the knee, at the joint line. So you can look at, you see patient positioning and clinician positioning in that picture. And then you're testing valgus and varus stresses there. Slide 23, we talk about special tests. And this is how we're testing for meniscus. So the first one is McMurray's test, and that is what is shown in the picture as well. So the hip and knee are flexed, and the examiner stabilizes the lower leg with one hand and laterally rotates the tibia. The other hand, as you can see, is placed with the fingers on the joint line, and the examiner slowly extends the leg. If a loose body is in the medial meniscus, the action causes a snap or a click, and you'll feel it, and they will feel it as well. Internally rotating the leg and repeating the test with them over the lateral line is how you would do lateral meniscus. I think of it as I'm stabilizing, and then also I'm feeling here and moving the leg in a figure 8 motion while straightening and flexing the knee. Thessaly test is one of the easier ones, and they will do it on their own. So let me see if I can show you this. So what they will do, there we go. So if you're testing this leg, you'll have them stand on that leg and bend their knee a little bit, and then have them twist in this motion, and that will force the joint together, and then that twisting will grind it a little bit, and if there's any catching or clicking or if it's uncomfortable, indication for a torn meniscus as well. And then the grind test, when we talked about chondromalacia, I talked a little bit about how you would test for that. So they would be straight leg. You would put your hand on top of their patella and kind of put some pressure to push it back into those grooves, and then you would tell them to make a strong quad. So they would flex their quad, and that would move the patella, but also you're applying that pressure, so it would push it back into the groove, and they will feel, it might be uncomfortable. You can feel crepitus, and then it might feel kind of like grindy, which is why it's called the grind test. All right, slide 24. We're talking about neurological tests. So here we're doing isometric testing again to test the myotomes. So hip flexion will test L1 and L2. Knee extension will test L3. Ankle dorsiflexion will test L4. Toe extension will test L5. Ankle plantar flexion, foot eversion, or hip extension will test S1. And then knee flexion will test S2. We can also do 3 different reflexes here in the lower leg. A patellar reflex, the Achilles reflex, there's two reflexes, but 3 ways to test them. So patellar tendon and then Achilles. You can test the Achilles forwards or backwards. And then the picture on the bottom also shows the anterior and posterior views of the cutaneous patterns. So that's what you would be if you're touching on both sides and testing sensation in these patterns. All right, so that is what I have for you on the knee. You do have one assignment for the knee. And then I will email you guys later this afternoon or evening talking about end of the quarter, last day to turn things in and all of that, and then how I'll do grades for you all. So if you have any questions, please let me know. These slides are up for you, and then ankle will be coming really soon after this.